Good morning, colleagues, and good afternoon to those who are in the afternoon. Welcome to this meeting, which we are hosting physically in South Africa at the University of Pretoria. As you can see, my name is Dr. Edith Madela Mtla. Welcome also to those who are online. I'm not sure how many colleagues are, but we thought that maybe we should give some 5 minutes for more people to join, and then we can start at 10:05 prompt. Thank you. Good morning again, colleagues, especially those who have joined us since I last introduced myself. So we're going to start right away. I'm going to do the opening of the meeting. So our meeting today is on climate change and One Health. We're looking at evidence, priorities, and challenges from India and South Africa. And we're going to have colleagues presenting from both sides. So I'd like to welcome you again, those who were not here when I first did so. And just introduce myself very briefly. I am working at the University of Pretoria as a senior lecturer in the Department of Family Medicine, and also I'm a researcher at the Community-Oriented Primary Care Unit. So today's meeting is really looking at the challenges that are being imposed by climate change on One Health. And as you know, One Health is an approach that that dictates that the ecosystem cannot be separated from the health of all humans, animals, and plants, and their living environments. However, climate change does threaten this ecosystem in that it will threaten our access to clean air, to safe drinking water, to nutritious food, and safe shelter of humans and animals alike. And also plants are threatened by climate change. This meeting happens at no better time than what South Africa has just experienced over the past 2 days, where we've had floods in the Eastern Cape that have caused a lot of devastation. People are homeless, people are hungry, schools have been destroyed, kids cannot go to school. And just last night, we had another disaster in KwaZulu-Natal, where a tornado came out of the blue from nowhere, and it just destroyed households in Tongat. Some of you may have seen those. So colleagues, we really need to give this our serious thought and look at all the evidence and maybe also generate more studies that are going to put in place evidence that generations to come are going to be able to use. So at this point, I'm going to introduce who would have been the first speaker, and that is Professor Zoe Jordan from Australia. Unfortunately, Professor Jordan cannot join us at this meeting, but a video is going to be played where she's going to address the meeting. So let's look at the video and listen to what she has to say. Thank you.
Hello and welcome to the JBI gLOCAL Symposium. This is an event that's really designed to engage clinicians and parents in practice. For those of you who perhaps aren't familiar with JBI, it's really our about practice. So using the best evidence to get good outcomes. Now, recently in recent weeks, I've been thinking a little bit about this idea of a climate effect, and it's the original concept came from Jim Collins. And what Jim talks about is the fact that organisational change never really there's no magic bullet, there's no solitary brain. It's about having consistent attention to something to drive change and to make organisation change. And I really felt like this is also synergy with evidence-based healthcare and the forces that drive the success in translation of evidence into practice. Hopefully, most of you are familiar with JBI and we recently launched a paper about the idea of evidence-based healthcare flywheel. And what we did when we rebuilt the model in 2019 was to add these overarching principles, but they're underneath, so they're kind of foundational principles around culture, communication, collaboration, capacity. And really we see these as catalytic mechanisms that are required to successfully drive forward evidence-based healthcare initiatives and organisations. Now, we certainly recognise that evidence-based healthcare is relational, it's not transactional. And if we want to empower to change behaviour, then we really need to be something careful, thoughtful, and consistent attention to navigating the relational magazines that organisations are run by. We don't want to reinvent the wheel, we just want to get it moving. And so, as you can see by this graphic, we really feel those insights that we added several years ago to the drivers of the momentum required to get evidence into practice. And I think that's a really focus area that we probably haven't taken sufficient attention to. Talk about them very much and articulate them, but we know that they are things that require attention in order to see change happen successfully. So I'm really excited that this week we have 35 global events. You have to remember that this is an event that started as the local solution here in Adelaide a few years ago. And really, it was just an effort on our part to re-engage with stakeholders across South Australia. But when we shared the concept with our international collaboration, they were really excited by it. And so over the years, we've seen the number of events grow, and now we have an extraordinary number of events, which is just so exciting for us to see. We know that change with just one person or just one person. And so we're excited to see the ripple effect of change that came from the event, and we're excited to see the ripples that will now I hope that whatever event you're participating in this week, that you have a really enjoyable time, and I look forward to hearing more about them. Thank you.
There you heard it, colleagues, from Professor Jordan. And let's hope that she has planted a seed that a lot of us will take forward. But it's very encouraging just to see how the JBI activities have spread globally. And we really need to generate a lot more evidence so that we can share it and have a direction. So at this point, as you can see, Prof. Jordan's talk was expected to be over 30 minutes. So we do have a couple of minutes that we need to spare. And since you cannot even ask questions from here, we thought that we should take this opportunity just to introduce more of who we are at the University of Pretoria as a partner in JBI. So as I said, I come from the Department of Family Medicine within the University of Pretoria. And the department has a research unit called the Community-Oriented Primary Care Unit, which is doing quite a lot of work in the communities. And in fact, it's in the process of applying to be upgraded to a platform because of the transdisciplinary work that it's doing, which is very much around One Health. The unit is headed by Professor Yanni Hugo, who's going to be chairing the next session at 10:30. So you'll get to see the actual face of the unit. And the unit is actually doing a lot of learning activities for undergrad and postgrad students. It's also doing research. In terms of research, it's not just our research, but we also act as a collaborator and a host for other faculties and departments that want to conduct research in the communities where we have a presence. And these are mainly underserved communities like your informal settlements and townships around the city of Tshwane in Pretoria. The other leg of what we are doing is then service. We deliver a COPC implementation service through which we do implementation research. And how does it work? It works through having a cadre of community health workers that go into households and do assessments. And the assessments are not only around health issues, but they are around all the needs that need to be addressed in terms of those communities. So the transdisciplinarity aspect then comes into effect where we mobilize other partners to come and intervene where health services cannot intervene. In terms of the health services, we deliver a comprehensive primary healthcare service in the form of a community clinic called Dashboard. It's also called a student's clinic because it hosts on a very regular basis an army of students from all sorts of disciplines, of health disciplines in particular. But we do also get students from other faculties like veterinary science, like architecture, like psychology and so forth. And this clinic has satellite clinics in the informal settlements of Tshwane. So in the delivery of health services, we then expand the services to the communities via these satellite clinics, which are in the form of containers. They are not ideal, but they definitely serve the purpose. So that's who we are. And we work very closely with communities. We do a lot of community engagement through working with community leaders in each of the areas. And we collaborate with non-governmental organizations and faith-based organizations that are in the areas where we work. So we try to be very inclusive in the way that we implement COPC, as it's called. At this point, so far, we have had lots of collaborations with other universities as well, and including universities outside the country. We continue to expand our network, and we're hoping that once we become a platform, our network will expand even further because we're going to have research champions that are going to drive each of the areas that we've identified as key areas that the platform should drive. So at this point, I'm going to stop introducing us. I could take the whole day just talking about what we do because we're very passionate about it. However, we would like to give an opportunity also to our Indian counterparts just to introduce their partnership and the center where they operate from. Thank you. Yeah.
Thank you. May I have the, co-host option?
I think.
Aparamita, you can.
Yes, I can present. Can you see my screen?
Yes.
It's not giving the full screen option. I don't know why.
You need to download it first.
Yeah, I have downloaded it.
And then, from the document section, downloaded section, then you have to open it. Not from
I
the
did.
browser. You have been using the browser.
Okay, just a moment. Can you see
Monica,
it now?
I think the issue is you
No.
downloaded it as a PDF file. You need to have it as a PowerPoint. Can I perhaps share from my side?
Yes, you can. Please go ahead.
It has come up, I think. Is it showing?
No, I think let them show it. It would be better.
Okay, okay, okay. Okay.
Please do it. So, MANT, an NGO that has been working in the state of West Bengal, that is eastern part of India. Next, please. So it has started way back in 1960, and with a mission that education is the panacea of all evils. So they established one educational complex starting from nursery school to the degree college. At present, we have been working in 6 verticals: education, health, community media, livelihoods, climate action, and research. We have been covering eastern and northeastern parts of India with 116 people. Primarily the indigenous development focus, and we have 3 people from the tribal community to be the member of the executive committee of MANT, the supreme body of MANT in terms of implementation or management of the projects, touching more than 1.5 million lives annually. Next. So yeah, so we have been touching almost all SDGs bearing 8, 9, 11, and 12. Next. And we have been covering almost 13 states in India, because of our research activities are covering almost 13 states. So that's why we have been covering these 13 states along with 3 implementation, three states where we have been implementing the projects. Next. So this is the kind of a milestone that we have started way back in 1960. Education was the focus. Then from 1999 onwards, we have started to work on public health. From 2010 onwards, we have started to work in community media. So we have been running community radio station, community video station, then livelihood promotion programs. Then in 2017, the Center for Public Health Research. And in 2022, we have started the People Science Center for climate change and climate mitigation related activities. Next. So next. So education is the focus that we have been working with the tribal communities, and we have set up almost school, colleges, and the libraries are there. So almost 7,500 students have been studying right now. Next. So at present, we have been also running, non-formal schools for the tribal children to mainstream them, because the language is a huge barrier. So we have been providing language support so that they can use the innovative pedagogy and can learn the syllabi of the government in their own language. So that is what we have been doing on a regular basis. Next. Next. So in health services, we have been running mobile medical clinics in various parts of the state, West Bengal, where there is no healthcare services. So we have been providing healthcare services directly to the people, like primary healthcare, reproductive and child healthcare, then basic diagnostic facilities, as well as radiology facilities. Next. So we are also involved in indigenous adolescent health. So we are working with the support from the University of Gothenburg, and we have been campaigning for their health and rights program, so that they are be able to have a better health in the future. Next. So maternal and neonatal care is basically being supported by London School of Hygiene and Tropical Medicine. So we have been using the tribal women's talent, so that to reach out to the people directly through them, and can provide healthcare services by the local government, so that that their coverage would be higher, as well as optimal utilization of the existing healthcare services provided by the government would be ensured. Next. Infectious disease control program, we have been working for last almost I think 5 years, especially after this COVID program, COVID problem. Next. Non-communicable diseases are the major focus. Till 2007, we have been working on this. So in tobacco control, we have been working as a nodal body in the state. We are also working with the state government as well as the local government, so that the tobacco control could be a part and parcel of the non-communicable disease prevention program. We are also working in cancer prevention as well as, diabetes prevention. Next. So of late, we have started to work in TB also. So we have received Stop TB grant and we have been working with them. Tribal communities are the major focus and they are leading this very initiative. So we have been, organizing various programs like, this fashion show by the tribal women, because the fashions are basically the statement that has been used for the purpose of, transmitting the messages. And I will show you why we have used this fashion show, because of the livelihood promotion program. Next. Next. So the sustainable fashion that I have already told you that we have been working for last almost 10 years in sustainable fashion. So the tribal women have been producing their own fabrics and they have been producing their own garments. And by using the motifs, the traditional motifs, and they are very, very unique. So we have been working with them, and that's why this very fashion show is being organized as a part of this very TB control program also. Next. So tribal art and paintings, what I have already told you, they are unique in nature, and so we have been also promoting this. Next. And of late, we have started to work on the creation of resilient local economies. So we have been using various production centers like non-edible essential oils, like the non-alcoholic products, chemical-free cosmetics, handicraft products, as well as medicinal products. Next. Next. So what I have already told you that we have been running community radio station, and in the right hand side of my presentation, she is the first tribal women radio jockey in the country. Next. Community video. So community video is basically the tool thereby we are using the women's talent so that they can show their natural gifts to reach out to the people in their own language. I must tell you that where we have been working, there is no media. So there is no radio station, there is no newspaper, there is no TV, or magazines. So these very community media initiative is giving them the power to share their own stories, their anecdotes, as well as they are sharing their own problems and plights, so that it could be reached out to the people who are at the helm of the affairs. Next. Next. So we are also working on the tribal culture preservation and perpetuation, because this is the area where we can reach out to the people more and more, and thereby we can reach out to their heart. So that's why we are giving so much of importance on this. Next. So the last one, that is the People Science Center that we have been we have started. So it is a conglomeration of activities. So media type activities have been doing. So promotion of climate smart agriculture, rewilding, development of indigenous community seed bank, water body restorations, and all those stuff. Next. So this is the rewilding. Next. Agriculture, climate smart agriculture. Next. Water body restoration. Next. Nutrition rich native fish varieties. Next. Empowering communities for mangrove plantation. So that is, we have just started in Sundarbans area. Next. That is the cyclone capital of the world, that I must admit. Next. So we are also in child protection and safety net. So we have been working for prevention of child marriage, child labor, and child sexual abuse on a regular basis. Next. Next. So we have been running the CPHR, Center for Public Health Research, and we have various departments also. Next. So we are the DSIR certified, organization, because the government of India is very, very keen to, give the certification whether we are eligible to participate in research programs or not. We are also JBI affiliate center, and we are under the process of, getting the ISO certification. Next. So these are the research areas where we have been working: implementation research, policy research, evidence synthesis, primary research studies, and health economics. Next. So we have various memberships, international and national ones. Next. We have the academic as well as, institutional collaborations. Next. We have research innovations also, because we want to make the health economics accessible to the all people, so that we have come up this web-based calculators. So these will be available, and we are also working two more calculators that would be available very soon. Next. So we are going to start this doctoral training program as an affiliate center of the Manipal Academy of Higher Education very soon, from September onwards. Next. These are some recent publications. Next. So new grants, we have just received a grant from NIH USA, and we have been working on, climate change impact on health. We have just started that one. Next. So these are the, various academic partnerships with various universities. Next. We have received various awards as well as research, best researcher award. Next. So these are our partners. Next. So thank you very much. I hope I am in time. Thank you.
Thank you. Thank you very much, colleagues from here and from India, to take us through a quick tour of a wide range of excellent work that you are doing, and we are glad that we could work with you in some of this. The next session is about climate change and One Health, a global and regional evidence. That would be by Dr. Parameswaran, and then climate change and One Health, a South African perspective, from Dr. Sean Patrick. So we first give to Dr. Giridhara Parameswaran, and he is an infectious disease epidemiologist who has done a whole range of cohort and community-based studies, a lot of work done during COVID-19, and he's from the Clinton Health Access Initiative in New Delhi, India. Over to you, Dr. Parameswaran.
Yeah, thank you for the brief introduction. So I will just, get into the presentation straight away. So the topic given to me was something that is pretty important, and something that is very, thought of as well, because, and I would say that it's not something that, we could probably cover it within just the 15-20 minutes that's been allotted to me, but I will try to take some very specific and very important issues that could probably be guiding the audience in this presentation. So the topic is climate change in One Health. Next slide. Next slide, please. So I'll be walking you through these different sections. So essentially understanding the broad definitions of climate change, One Health. And because climate change is having a lot of, direct and indirect effects, I would like to take the focus into antimicrobial resistance, because that is one of the less understood, less prioritized infectious disease issues currently in the developing world, and how climate change is actually contributing to disease resistance and what are the different pathways. And then, few examples of such instances when infectious disease outbreaks have happened because of climate change. And then few bits and pieces on how climate change is, affecting the food production and antimicrobial use. And then finally, some global, tidbits on what are the policies and driving interventions and pillars that are being made part of the quadripartite that was signed recently last year. So next slide. So it's pretty hard to just say that, okay, now One Health is a kind of an approach that combines human, animal, and environmental sector. I mean, the picture is self-explanatory, but when it comes to the ground realities and how all the different programs in the country operate, it's not that easy, as it's been said, right? Because each have their own budget, they have their own operating frameworks, the kind of collaborations that it requires, the kind of communications that One Health approach requires is still under development. And these are like potential areas, for organizations and implementation partners and other stakeholders to really test strategies to show that, okay, this is potentially a way that communication can improve, so on and so forth. So this diagram just shows you broadly that the sectors involved are the human, animal, and environment. And simply, directly, you can just say that climate change is something that is affecting your environment side of things. So that's the kind of essence of the broader topic that has been given to me. So we look into the climate change, how that is actually impacting human health. And in the center, you can see, as I said earlier, this requires a lot of coordination, communication, capacity building, thought processes, prioritization, so on and so forth. In my best, review from whatever I've seen, I've just saw one definition for climate change so far, because it says that it's a long-term change, because weather is something that is temporary, which can change day after day. But climate change is something, it's a long-term cumulative effect in the weather patterns that have come to the Earth's local, regional, and the global chain. So that's the broad definition. One Health, it's been officially defined by the WHO in the quadripartite document as an approach wherein you give equal priority and importance to all the three sectors when it comes to research and implementation. Next slide. So here, as I said earlier, this is such a broad thing, and we can have a huge summit wherein you can speak on agriculture and effects, weather and effects. You can speak on economics. You can speak on social issues. You can speak of, the industrialization and stuff, and so on and so forth. But I would like to show you just, if you can see on the bottom right side, the effects. I'm just going to look into how diseases are going to be affected, or rather what kind of challenges and what kind of issues that the human race is going to face because of infectious diseases if we don't control climate change. So you can see on the left hand side what are all the things that are going to happen because of climate change. So you know that sea level is going to rise, so that's going to cause issues of coastal cities and towns. And then because of heat, there'll be loss of capacity, so indirectly affecting economics and the the productivity of the entire labor force. Then wars can also happen. Now that's a different pathway altogether that we don't want to get into. That's more of a geopolitical issue. And then, of course, last but not the least, water and sustainable use of potable water is also going to be issues in places where it's going to affect the livelihoods. So this is the kind of broad thing, but as I said, I'll keep my focus in the bottom right. Next slide. So why I have chosen AMR? Because among infectious diseases, it's something that's not rather prioritized in the last that 1 or 2 decades, because it is an issue that is a classical example that can be tackled through a significant or a really impactful One Health approach. Currently, whatever programs that we see in terms of priority or in terms of budgeting, in terms of national leadership or international leadership, it's more in the human health sector. But AMR is not such a thing wherein you just focus on the human health, you will get away with it. Absolutely not, because it has got different kinds of influences from sectors beyond the human sector. So that's the reason why it is a very, very, very classical One Health issue. And how climate change and AMR related is what we are looking at. So these are just broad statistics and explanations. I don't want to take much time here. I'll just go to the next slide. So AMR and antimicrobials are actually, the issue is right now, all the current antibiotics that are there in the market across the world, I mean, they're slowly losing their shelf life and their, potency, primarily because of irrational use in humans and animal sector. And this is also, the issue is augmented because there is no new antibiotic development happening in the pipeline, at least in the pharma-rich countries like India, South Africa, and Brazil. In my previous association with the One Health Trust, currently I'm with the Clinton Foundation. So there is no budgeting, there is no real investment when it comes to developing new molecules and new antibiotics. So whatever antibiotics you see right now in your hospital shelves or in the OPD pharmacies, etc., their life is just counted for the next 5-10 years. So it is prudent as researchers and people working in the policy space to understand that any intervention that is going to curb AMR. It could be through climate change, of course. It could also be through good stewardship practices, which I'll be covering soon. And it could also be other interventions that the quadripitite mentions. It's very important that all these will have and require a One Health approach. And the worst scenario that we actually foresee, given by the modeling estimates, is that by 2050, which is the next, roughly 3 decades from now, close to 10 million deaths could be attributable to AMR. Next slide. So this slide is just a simple example and a summary of how pathogens have evolved and how they are, trying to develop the resistance genes and the capacity to become more pathogenic, more transmissible, and more infective to the societies where they are prevalent. So, for example, you have all the waterborne, pathogens, and like the Campylobacter, Salmonella, Vibrio cholerae, they're slowly becoming heat tolerant, and because of that heat tolerance, their ability to cause widespread pandemic, and at the same time, their ability to really win through the existing antibiotics and therapy modalities is also increasing with time. So that's some example of the foodborne diseases. But the most classical example is the one that I could mention about the SARS-CoV-2, our recent pandemic, which should give us some lessons on climate change and One Health. The aridity and the prolonged droughts actually made the bats in China to migrate and go to places where they have not been before. So there they went on to infect some secondary carriers or a primary carrier that then came in contact with humans. So it's a classical example of how climate change is indirectly, or rather if you know the pathway, you can say directly is also affecting the infectious disease paradigm. Next slide. So this is another 2 examples. So in Accra, Ghana, so what has happened is essentially there were lot of flooding because of climate change, and if there is flooding in a really resource poor setting wherein you don't have good sanitation or drinking water supplies, you're prone to have outbreaks. So that an example of outbreak was traced back because of rising levels and unpredicted floods in that area. And one other very classic example was the 2016 outbreak of anthrax in Siberia. Siberia is supposed to be one of the coldest geographies in the world, but because of climate change, a significant amount of the superficial ice actually got, melted. It actually, gave rise to exposure of some reindeer that died probably like centuries ago. That reindeer was actually infected by anthrax, and anthrax then spread. So these are like some kind of things that, it's not something scary, but that's something that we need to be wary of, so that if you don't do things now, then there's no point in crying or after like 2 to 3 decades. Next slide. So what is the impact of climate change on food production and antimicrobial use? So global food security is actually under threat because when your climate change is actually happening, so you're prone to have less rainfalls, severe droughts. So that's actually going to challenge the existing food supply system and the production systems and the agriculture farms. It will create economic and social losses for the farmers and the farming communities. So that's some kind of things that really is actually being, documented and actually happening in the world. So as these things are actually going to grow and grow, there'll be increased demand for more food because the population is never going to get controlled, at least in the highly populated countries. And that's where this challenge and this threat is even more looming. So the demand is going to increase. So the farmers and all the food production industries will try to amp up their supply by probably using more antibiotics because you need more animals for catering to the protein. You will also require more pesticides, insecticide use for ensuring that the crops are developed quickly, more genetically modified crop production, and all that will happen. So this essentially, it all boils down to, I mean, as I said, it's kind of a nexus of pathways, but at the center of which is climate change. Next slide. This is just a very simple and broad depiction of how AMR and what are the different sources. I wouldn't rather like spend much time here, but you can just see the kind of different pathways that are here. So you have the pharmaceutical production plants that are discharging effluents, hospital wastes, and also the urban communities. So that's one of the ways that AMR is spreading within the cities. In the rural areas, you have animals, the animal husbandry, and then you have the landfills and the agricultural crops where potentially antimicrobials are used, and then they get into the food chain. And last but not the least is your environment. So you have, the treated water in sewage, and then you have the river bodies. So these would directly, indirectly get affected not just by antimicrobial use, but also because of climate change. Next slide. Now, what are the interventions? Now, I've been speaking a lot that, okay, this is problematic, hey, this is a problem, you need to do something about it. So these are some set of things that broadly are One Health set of interventions that have been prescribed by the quadripartite. Essentially, a kind of a meeting where the human, animal, and the environmental stakeholders came together and signed. They say that, hey, yes, we should work together. That is a kind of a great, you may call an achievement that has happened in the last year. But yes, whatever has happened at the global level needs to then come into regions, from the regions to the countries to the states, and the kind of coordination is required at the local level for any such impact to happen soon. So they would like to have good kind of national action plans, good data monitoring, surveillance systems in place, research and innovation that's guiding these data systems, awareness and education of the public. So there are multiple levels of interventions that have been planned. So the next slide, I'll just give you some few thoughts and then we can close. So this is the thing that I mentioned about the quadripartite. The pillars are essentially transmission, integrated surveillance, interventions, behavioral insights and change, and economics and policy, because there is no point in investing and doing things without knowing about the cost and the potential ramifications and the effects. So that's the way that these pillars have been built. And it's a tool that countries can actually use to understand how and where they stand. In this specifically, the quadripartite has been made for One Health, but I'm taking AMR as an excuse to show what is being given there so that you will understand how the quadripartite's main focus driving input was the AMR issue. So the next slide. We'll go to the next slide. Yes, so these are the highest research priority areas. Now we've been looking into different speakers, and Dr. Nirmalia had just presented about this wonderful work that's been happening in MANT. So currently, it's essential to understand how all these resistant microbes are evolving. So such kind of research studies have been done only by modeling, but there are no real tracking systems that are there in place, at least in India, to say that, okay, now this is a place and there has been a microbe of this kind of characteristic. After 1 year, you have a system that says that the temperature has risen by so many degrees, the humidity has increased by so many points, and that is actually showing some change in this pathogen. We don't have such kind of systems. So what impacts the transmission and the pathogenicity of these infections in the humans, animals, and plants, specifically in LMICs? I mean, as I said, this is a very broad global agenda, but within India, we can probably set systems wherein researchers can collaborate with laboratories and try to build systems to take, serial interval samples from animals or humans or from the environment to understand these kind of ways so that can inform policy. Then interventions. Now, I'm not going into integrated surveillance because I feel intervention should be first, and that intervention surveillance is actually part of the intervention, right? So how can a One Health intervention have impactful AMR control and mitigation? So, and can it be translated, scaled? Essentially, what works in India need not work in South Africa. What works in Nigeria need not work in Rwanda. what works in Malaysia need not work in Thailand, right? Because the context and the political scenarios, the kind of leadership, priorities, budget, everything is very different. So research should be looked in such a manner wherein you are able to build systems in such a way and create evidence that can be translated and scaled. There's no point in just you publish it and then you get an impact factor and that's about it. No, it's about taking the research in a manner wherein it can be used in multiple contexts, trying to understand the economics behind it, how it can be used, what kind of strategies and frameworks need to be used so that it could be more successful and scalable. Lastly, as I said, economics and policy. I shouldn't say that behavior insights and changes are not important. It is definitely important, but it's not my forte. And so it will not be right for me to say, but it is also listed as one of the priority areas for the people working in the social and the behavioral sectors as well. So good IEC and awareness campaigns, priority building in the policy and the stakeholder level, that's also very essential. At the economics level, yes, the governments need to prioritize, they need to identify, and for that, what kind of tools and what kind of evidence is required. Essentially, cross-cutting sector-specific policy options, and you could give them cost-effectiveness ratios. You need to do some financing strategies, identify what potential pathways are already available with the government so that we can build strategies on and above it rather than building parallel systems. So these are some ways that, broadly agenda has been set for AMR. There have been climate change set of things. It's not that something that as I said, I'm not trying to say that we are trying to address climate change. It's a global agenda. So it only happens once people understand the green carbon issue, the greenhouse issues and the carbon emission effects and all that. But as AMR, I think this is some very good example of how climate change being an environment issue is actually creeping into resistance and patterns, change in patterns in the bacteria and the pathogens that you see around. So I think this could just give more thought process to researchers to understand and devise what kind of research questions and what kind of ways that the research can inform local and the country level policies, because it could be in line with this global agenda. With that, I am done. Next slide. Thank you.
Dr. Gopal, thank you so much for a very clear and insightful presentation to show us the big picture. It is quite intimidating, but it shows that some things can be done. The questions will be taken. I just want to acknowledge my co-chair, Dr. Nirmalya Mukherjee, who's actually the director of MANT, and he will manage the questions and the discussions. I'll just, so Dr. Gopal, you will stand by for the questions and the discussions after Sean's presentation. Sean Patrick is in the School of Public Health. He's one of the people at our institution who is excellent at transdisciplinary work. He works with whoever moves. He even works with my son who's in architecture, and he has done a lot of work, and he's going to talk to us about perspectives on One Health and climate from South Africa, and he's got experience with his feet on the ground, so we're looking forward to you, Sean. Go ahead. Thanks.
Thank you very much, Prof, for the kind introduction. Will you share the slides from your side, or should I share from my side?
If you are able to share, can you please share from your side?
Okay. Can you see my slides?
Yes, we can see. Thanks. It's clear. Thanks.
Great. Thank you very much. Again, thank you everyone for the opportunity to share a bit about the research we're doing.
Just
Yes.
put it on presentation mode.
Okay. Can you see it now?
Yes, excellent. Go ahead. Thanks.
Fantastic. Thank you. And thank you again for the opportunity. So the work that I'm going to share with you today is primarily done in the research facilities that I'm involved in, as part of the environmental chemical pollution unit, where we do a lot of work around monitoring around the contaminants that have a pretty great influence on climate change and One Health. The UP Institute for Sustainable Malaria Control, in some of the study sites are working in, we're primarily seeing where there are these great effects of climate change. And then in order to really to make a change, I'm also part of the Center for Environmental Justice, and there are some of the issues and concerns we're seeing where we actually need the communities to be involved. So I'll also touch a bit about that. So I'm actually glad that the previous speaker gave a good introduction around what is definitions of climate change and One Health. So I won't spend too much time on that, but I'll touch a bit on the definition, the role in climate change as far as public health is concerned, as far as environmental health is concerned. Because I come from environmental health background, I'll also touch a bit more on the environmental health side. I'll share two practical examples of how we incorporate environmental health as well as some of the social interactions. And then I will end the presentation with an introduction to the COHESA project. And that is sort of the precursor to the talk that I'll give later around some of the work we're doing around One Health. So we heard now about what the definition is of One Health, and really, in essence, what it is like what Dr. Gopal had said. It's the sustainably balance and to optimize the health of people, the animals, as well as the ecosystems or environments that they are involved in. And really, what it does, it recognizes the health of the humans, domestic and wild animals, plants, and the wider environment. So very often we talk about One Health. We very often focus on public health, which is important. Zoonotic diseases, antimicrobial resistance, as we heard in the previous talk. But as far as environmental health is concerned, these are also issues around climate change, pollution control, which is more where the work that I currently do is really involved in. So throughout the talk, I'll touch on, if we're talking about One Health and climate change, how there's this interaction between what's happening in public health as well as environmental health, and how all of these actually interplay as far as climate change is concerned. So as we're talking about climate change and One Health, we do know that climate change does pose a huge health risk. And in this slide really summarizes a lot of the factors, with the demographic, geographical, the climate-related hazards, and we are seeing majority of these within our respective countries, as far as exposures are concerned. But more importantly, we are seeing what the effects of these can be on the individuals, and we are often focused on waterborne diseases and zoonosis, for example. But on the opposite side, we also need to look at mental health too. And there are some of the studies that we are planning on doing around looking at those. But also we do know that aside from all these exposures, we also know that to be able to address all of these, we need to be able to have the health systems and the facilities as well to deal with some of these future threats. So if you're thinking broader, I'll touch on two of my own examples, but if you're looking slightly broader in the University of Pretoria, we talked about the definition of One Health, and but I think it's about 2 years ago, about 4 years ago, University of Pretoria had the UP One Health for Change, and majority of us were involved. This was around the COVID-19 pandemic, looking at various initiatives, and we do have a whole website where we have dedicated to all of these issues around One Health. So there are many other examples within South Africa. That's not part of this presentation, but it is available on the UP website. But if we're looking specifically into where I'm focused at in environmental health, we do know that as far as environmental health really looks at from a public health perspective, refers to this branch of public health, looking at the natural, the built environment, as well as affecting the health of the individuals in the environment. And very often, if we're talking of One Health and climate change, we need to take into account that these environmental factors can potentially influence health. So what I done, I initiated a study, and this is part one of the study. Part two of the study has started recently. But really, we tried to look at what is the impact of climate change on environmental and social determinants of health. And if we're working with the communities, how do we develop this climate resilience strategy within the communities? So trying to identify, and as Dr. Gopal in his last slide talked about the pillars, looking at what are the social determinants of health, what are the health behaviors, for example, how they can be influenced by climate change and inherently One Health, and how do we propose this community resilience strategy. So the area that we are currently working in, for those who don't know, South Africa, it's in the north of South Africa, and it borders both Mozambique and as well as Zimbabwe. And the area is an ideal setting to study One Health and climate change, because you have humans and animals living in close proximity to one another. So zoonotic diseases can occur. You also have mosquito-borne diseases as well. But it's a great area to look at climate change, look at resilience, but also look at these issues around One Health. So the three study sites we have are there. So I'll just share three of the projects my students were involved in. The first one was a lot around monitoring. We talked about antimicrobial resistance, and for us it was to determine what are some of the products that are currently present in the water. Because if we know what's in the water, we can try and understand what the usage could potentially be. So I'll only touch on a few things, and I'll talk about the pharmaceuticals in the water. So we did a broad screen, and this is, I won't go into all of them, but these are the broad range of chemicals we found which are present in the water. We did a screening. So the screening is a qualitative approach. So whether it's there or not, next step will be to quantify. But you can see from this slide and on the next, there's quite a wide range of these potential or drugs that are within the water. And if you're thinking antimicrobial resistance, part two really would focus on what is the practices around the areas and why are these products in the water itself. We do know some of the herbicides, the insecticides, for example, it's areas of farming, so we understand why these are within the water. But this proposes quite a great challenge as far as clean water and sanitation is concerned. So the next phase really looks at what are these practices, and if it's a behavior change or a practice change, how can we implement that to have adequate water resources so that you do have access to for animals and humans as well in the area. So I have two PhD students working in the area, and one will primarily looking what is this climate resilience strategy, but incorporating things such as temperature, thermal comfort, environmental determinants of health. And this is just a very brief summary of what he's planning. But looking at, like we said, about the attitudes around temperature changes, looking at thermal comfort, because we do know with climate change, the area is starting to change. People's behaviors are changing, and how are people actually adapting to that? And looking at a study and seeing if we're getting a group of experts together, how can we establish this community resilience strategy in order to assist the community to adapt to this environment? But knowing that, we also need to look at the social side. So a second PhD student in the same area would look at these intersections between social determinants of health literacy, and behaviors, and try to understand what are the current social demographics in the area, health literacy. We are consistently giving health promotion material, for example, but is it culturally sensitive? Does it speak to the communities? How are people experiencing the area in response to climate change? And how do we develop this integrative community resilience framework? These are within the areas that are bordering South Africa. So it's one practical way on the ground to understand how climate change is affecting the local communities. And because these communities live in close proximity to animals in the area, bringing a One Health perspective in the next phase of study becomes quite important to understand how this interaction is taking place. But if you look closer to home at what Prof. Yanni had said now about the built environment and public health. If we're thinking of climate change and One Health, we often forget the buildings and the structures that we are currently living in. So we initiated a study a few years ago looking at architecture and public health. And if we're thinking when the climate starts to change, we often try and adapt our homes, whether it's adding in ventilation, for example. So that's one way of mitigating the increases in temperature. But we really wanted to understand what is this interaction between the living spaces, environmental pollution, disease dynamics in these vulnerable communities, in develop a strategy towards improving health and well-being, taking into account the issues we have around zoonotic diseases if they're living with animals in close proximity, or changes in the temperature. And you see we are quite a broad group of expertise, from architecture, chemical engineering, public health. So very briefly, we from our four respective fields, we all came together and we looked at, we mapped the study area from the architecture department. Chemical engineering developed the census for us. For public health, we looked at all the practice surveys, trying to understand the community in order to understand what this interaction could potentially be. So we published this beginning of the year, and what we came up with was this conceptual analysis of public health architecture nexus in these developing informal contexts. And the diagram you see is how we interpreted what what role each discipline should play. As far as public health is concerned, we have certain responsibilities in order to promote health and well-being. But from a structural point of view, architecture built environment should also take into account some of the issues around climate change, using safer materials, breathable materials. From the engineering point of view, there are many other issues that can come in as far as the different construction of new materials, but from the social determinants side as well, taking into account how we include opportunities for education and awareness, so that when we do get these issues in this changing climate, that we can address those in communities. So spinning off from this, it was then important to go a little bit further, and we'll be talking early this morning about this work done as far as COPC is concerned. We are also part of quite a large interdisciplinary study. We're looking at how do we work with the community to develop the research questions, but also work with the community to try and effect any change. So the study is in its second year this year, looking at co-creating wellness and human dignity in an area. And for me, it was quite a lesson in, if you're thinking of adaptation, whether it's to climate change, issues around interactions with the environment, how do we get a community involved to understand what the challenges are around health, dignity, safety, education, etc., and move that forward? The intention is long term to have these community an action plan where, taking into account the environment, and we know with the change in climate, you have changes in the drainage system, you have changes in access to water, access to care, but how do we integrate all of these together to ensure that a community becomes resilient to any change in climate, as well as any political climate for that matter? So this is something that we're planning to continue next year. So to end this talk with a last slide and thinking about climate change and One Health, and sort of a precursor to my next talk later. I'm part of a team, the COHESA team, looking at capacitating One Health, and we are a group of universities in Eastern Africa, as well as in South Africa or Southern Africa. And the idea is that around One Health and climate change, we develop this knowledge sharing network where we look at the status of the countries, as far as Dr. Gopal talked about antimicrobial resistance. What are some of these global action plans? How far have they really gotten as far as surveillance is concerned? What is currently occurring in some of these countries? So trying to share what the best practices are. We also look in terms of governance. So there are some of the countries that have better structures on some of the aspects, whether it's around policies or practices, how can we share these? As far as education research is concerned, we come together about twice a year and try and share what are the lessons that we have learned, but also more importantly, what are some of the these future the challenges we have in building this One Health workforce. In the next talk, I'll talk about what are some of these practical things about training this One Health workforce that we have discussed and what we have come up with. But lastly, what is more important and thinking long term about climate change and One Health is what are these these solutions, some of these issues we have, and these solutions can be things from training professionals, whether it's education, developing new curriculum, but it's really to strengthen the research, the innovation. We do know in the majority of the countries that are shown here, we have research institutions that have large numbers of funding. But how do we really all work together to build this community of practice where we can build this society-wide inclusive system to manage and resolve some of these One Health threats? So these are just some of the thoughts around practical examples, some of my own examples of climate change and One Health within a South African context. There aren't that many studies done in South Africa. So really trying to identify what the threats are and building the capacity in order to be able to be resilient to these threats, as well as ensuring the community is resilient. So I'd like to thank the organizers for inviting me to speak, and also to the funders making some of this work possible, UNICEF, Future Africa, and the National Research Foundation. Thank you very much, Professor Hugo.
Thank you, Sean. And yeah, you are also spot on with time. And over to Dr. Mukherjee. Thank you.
Yeah, thank you, Dr. Patrick. Very insightful presentation. I don't know whether Dr. Giridhar is available right now, because he sent a message that that he would be available afterwards because he has to attend a important meeting. So for Dr. Patrick, if anyone has any question. Any question? Any remarks? Or anything to add?
Yeah, I wanted to ask, it's Yanni Yuhu again. I wanted to ask Sean about the partnership between the universities. I'm expecting that he will share more in the next presentation. Do you also share curricula? Do you also participate in joint projects? Thank you.
Yes, Prof. So the idea was that the rest of the African the counterparts, they would need to develop curriculum within their own universities. As far as COHESA is concerned, COHESA wants to look at developing one cohesive curriculum that can be taught in all the respective countries. That's the long-term plan. So you would appreciate that that does take a lot of doing. So we had a meeting in February where all of us came together, and we shared our own experiences and what the need in each one of the countries were. So the idea would be to have a country-specific part of the curriculum, but in the end to have one cohesive curriculum. So University of Pretoria currently is the technical partner. So we really share most of the work we've been doing on the ground. We are looking at, we have developed a One Health curriculum, and I'll share in the next presentation what we have actually done and piloting it. And there's actually two that we are looking at developing. So in the next presentation, I'll share a bit more about that.
Great. Anything more? Anyone? Any question? So I think, the two presentations are very, very, insightful, and I must say that, as Giridhar is not there. So I'm just, taking his presentation as a cue that, that climate change exacerbates the AMR by affecting the human, animal, and environmental health. So that we all know. And raising temperatures, environmental changes contribute to the survival of this transmission of various pathogens, leading to increased health risk. And I must say that, the greater burden of infectious diseases would be, the major problem in a country like India or South Africa. So, from Dr. Patrick's presentation, that we must, think about, that how, the collaboration, because, he shared that various types of collaborations and integrated policies can be, can be ineffective, and, that can also prioritize the research and interventions, keeping in mind the One Health framework. So this is, very, very important, I think, aspect that we can think of. And we must have a kind of coordinated effort to address these pressing challenges. And it is not about only for India or South Africa. It's a global challenge, and we should fight together. Otherwise, it would be difficult for us, to address it. And one thing I must say that, the climate change is happening, and it is not waiting for anyone. If we can't address it right now, then we are losing our times. So thank you very much.
Yeah, I think now we will have tea time, and we join at 11:15. Or at what time? 11:45. 11:45.
So it is around 15 minutes from now. Is that you are trying to tell? Because Indian time is different. No, so that's why I'm telling.
Let's say 25 minutes.
Fine. So we can again reconvene after 25 minutes. Thank you very much.
Morning, afternoon.
Good afternoon, good morning. Once again, are you guys back from your tea of different size? I don't know what tea, green tea, blue tea. You all had that?
So in our case, it would be a lunch.
Okay. Maybe you always have lunch. Yeah. Thank you.
Hello? Can you hear me? Nirmallo?
Yeah.
Yes,
Yeah.
I'm here, Dr. Bhattacharya.
Okay. Right. So I am just giving over to Dr. Nonti Magida. She's a physiotherapist, so she will sort you all out. Thanks.
Thank you so much, Prof. So now we are, let me first introduce myself. My name is Nondembiso Magida. I'm a physiotherapist and one member of the JBI gLOCAL in South Africa. I, as a physiotherapist and a climate change, so for me, when you talk about climate change and I think of the rehabilitation, that the climate change is not only one-sided, but together with the rehabilitation, there is a climate change. That climate change, it causes that the rehabilitation reduces during the climate change because some of the patients, they are unable to attend their physical visit. As a result, there's a regression in the in the rehabilitation, which again, if you know, there should be, because we physiotherapists, we do mainly the musculoskeletal and we're doing the respiratory. So as the temperature rises, the arthritis or the joints, they get stiff. So, and then when the temperature, when the chemicals go down, the arthritis is getting worse. Whereas the other way around, if it is increasing. But anyway, that's not my duty for today. My duty is introducing. Now we're going to talk about the climate change lens within the health system, and Dr. Rajiv Sadanandan from India will present. And I'm very sorry if I have say the name wrong. Dr. Sadanandan possesses expertise in the field of health system and financing. He held the position of Health Secretary of Kerala and spearheaded the overhaul of health system with a particular emphasis on enhancing primary healthcare, diseases prevention, and health promotion. In addition, he has overseen the management of tuberculosis control, HIV/AIDS, health insurance, and cancer control initiative. He has occupied governmental posts and participated in technical committees like UNSAID and WHO. Currently, he holds the position of commissioner on the Lancet Global Health Commission and serves as the honorary advisor to the Chief Minister of Kerala. Thank you so much, Doctor, and over to you.
Thank you, Chair, for the kind introduction. Can I share my screen? Am I?
Yes, please share.
Does it work? Are you able to see my screen?
Yes,
sir.
it is clear.
Wonderful, wonderful. Yeah, thank you. Give me a minute, please. Yeah, my name is, as the chair told you, my name is Rajiv Sadanandan. I used to work in government before I left government, and my exposure to, or my most of what I am saying today comes out of my experience of working in the health sector.
Sir, 1 point, sir. It should be the presentation mode, sir.
Oh, I'm sorry.
Thank you, sir.
Thank you. Is it now? Is it okay?
Yes.
Yes. Thank you. So in the past, when I joined the health sector, we knew nothing about climate change and its impact. In fact, the first time it struck us was in 1998, when we had to deal with the first dengue epidemic. What happened was there was unseasonal rains, and normally when there are rains, we produce a lot of rubber. And as you know, if you know the way rubber is collected, the milk is collected in small pots that are left in near the trees. So during unseasonal rains, what the planters do is that they cover it with plastic. But that year, the price of rubber fell, so nobody bothered to do it, and mosquitoes had a field time, proliferating. That's our first exposure to dengue, and we thought that dengue would grow from peridomestic mosquito, but we didn't know what the species which actually could grow in the wild. Since then, since the 2008 and so on, the other thing that I used to notice was every year when there was a warm temperature, the infection of dengue and malaria would go up. Not only that, the dengue hemorrhagic fever and the number of deaths that would come out of it would also increase during the warm period. What I didn't know at that time, and what was proved later, was not only does the temperature work with the vector population, but also impacts genetic modification within the virus, which actually increases the virulence. Since then, climate change has become kind of very common to discuss in health areas. And my apologies, I couldn't join you earlier. I hope or I expect that many of the things that I'm going to mention might already have been covered. My apologies if that has happened. So, or maybe somebody can just caution me and say, hey, move on, so that I know that it's already been covered. Now, this is, again, it looks ridiculous saying it at this age, but even now, there are people who are disputing the impact of climate change. The climate change person, forget about health. I think it is there's very clear evidence that the environment is getting warmer, and in the case of health, more than absolute changes in temperature, what in climate, what matters is increased climate variability. I'll explain why a little later. This is amplified by human actions, and it kind of works together to impact health. When you analyze the impact of climate change, we do it on two axes. One is the direct impact, which comes from warmer air, storms, floods, etc., or through intermediating factors, on nutrition, forced migration, etc. The sad part is that for many of the people who are who are attending this presentation, the impact is inequitable. The countries that have less warm area actually might, in some areas, might even benefit. But many of us who come from the warmer regions will actually stand to lose. And also in the community, also the people who cause the least destruction to the environment, that is the poor, suffer the most. Now, it's not. We can't just wring our hands and say we can't do anything, because the problem is aggravated by human intervention, and it's up to us to reduce the impact, either by reducing factors that impacts the environment or adapting to the changed conditions. Now, this is I borrowed this from the Lancet series on climate change. Will someone tell me whether this has already been covered? Because it's so common that it would have been covered already. If that is the case, I can move on. The impact of climate on health. Has that been covered in this webinar already? Or do I need to spend time on this? Okay, I guess the silence means that it has not been covered. So I'll briefly run over this. And most of what I'm going to expand on is actually based on this. There is a natural change in the environment due to various reasons, and human beings compound it, which leads to climate change. And its impact is felt through extreme weather events on ecosystems like land and sea, through sea level rise, through environmental degradation, which has got its health impact, which I have listed on the last part of the slide, which is thermal stress, microbial proliferation, change of vector pathogen host relations, and impaired crop and loss of livelihoods and displacement, all of which have health impact. Now, why is this a problem for health sector? As I mentioned before, none of us knew about an understanding of climate variability, its impact on health, with the result that most of public health is actually about anticipating and taking preventive action. Now, our inability to anticipate climate variability is leading to problems. In public health, most of our strategies are based on seasonality. If it is this month, it must be malaria. If it is this month be something else. All this is now changed by unseasonal heat waves, rains, etc. So what we studied in the past, that this is the time we should expect, all that is changed, and impact can hit you anytime. The persons who suffer from chronic diseases, mental health issues, and people who have an adverse health episode such as cardiovascular incidents are most vulnerable to the impact of heat. And the other challenge for the clinicians is that impact of climate change on disease conditions is now our awareness, our knowledge is still growing. The problem is that what should normally form part of the clinician's assessment may not be anticipated, will attribute to something else, and leading to misdiagnosis and mistreatment. That's a major problem that health sector is facing today. That most of our institutions themselves are subject to adverse climate conditions. For example, our wards are not air conditioned. The patients and health workers are left vulnerable to heat impact. And those of you who have had to deal with floods would know that our hospitals and our primary care centers are not located in flood-proof areas. So at a time when we should be providing support to the population, we will actually be we'll ourselves be victim to it. Our people would be affected, our buildings would be affected, and so on. Now, I think I'll skip the all this and go straight to the challenges and if you have time, I'll come back to the slides later. As I mentioned before, the unpredictable climate variability is creating a lot of problems for public response and unplanned response. We have to respond urgently. Then most of the knowledge that is available today on the impact of climate on health is available from the OECD countries. There's very little research that has happened in our countries, where for us to understand what is the impact of climate change on the context of poor countries, including the diseases that are common to our place and to the way our hospitals are structured. Now, climate change, as I mentioned before, partly it comes directly, but partly it is also coming through other pathways like nutrition, etc. Now, how do you separate the impact of climate change from these pathways, which would have happened anyway? And that's a major problem for health planners. Any research that happens on health will happen in partnership with other sectors. So, and health guys we are extremely averse to collaborating with others. So it's a challenge for us to work with climate and environmental experts, zoologists and botanists, entomologists, and so on. So the reason that very little research is happening in health, the impact of health impact of climate on health, is because this collaborative research is something that we are not familiar with. With methodologies have to be raised. Remember, what we do itself is also contributing to climate change, and we also have a responsibility to reduce the impact as our responsibility to controlling the environment. Chair, may I know how much of time I have left? I'm sorry, I've not been tracking time.
2 minutes. So 2 minutes. You can continue.
How many minutes do you have?
2 minutes.
2 minutes. Okay, then I think I'll go to the concluding slide. Then I'll skip this part. Now, one of the limitations that we have is that health is a downstream recipient of the climate change. It works through other ways, and if we have to make an impact, there are some areas in which downstream interventions can happen. But beyond that, most of the effective interventions will actually have to happen upstream, which means that to create an impact on health, we would have to work with the other sectors through which the mediation happens, and even further upstream to work with the determinants of health. So the ability of health sector alone to address this is limited. As I mentioned before, any action will require not only intersectoral but also inter-country collaboration. Climate change is one area that tells us that we are all in this together. So what happens in one country will not be limited to that. It actually will impact the others. Now, the impact on the North, which has a larger say in the global decision making, and on the South are not similar. The urgency that the poor countries feel is not shared by the rich. And we have increasingly seen that these negotiations to control not only climate change, but also infectious diseases see a great mismatch between the requirements of poor countries and the rich countries, which is again going to limit the impact of the amelioration that we can effect. Now, as I mentioned, we also need to find ways of reducing our contribution to gases. experience of extreme weather events which have repeated themselves have shown that when the problem is well analyzed and we adapt to new situations, human societies can actually reduce the impact. So rather than shrugging off this as something that we have to live with, it's important that for us to recognize that there is a problem, which again is not very common in the health sector even now. And secondly, changing practices, in city planning and water supply, afforestation, etc., so that the direct impact is reduced. Now, coming to city planning, you're all familiar with the impact of the urban heat island effect. Changing that to some that and one of the areas where it has a lot of impact is on human health. Now, and changing that is again something that we need to start discussing. Going forward, the impact of climate change will be even deeper on health sector, because when you live in urban areas, the impact is always amplified by the city planning. More populations are now moving to urban areas, which means the number of people who are vulnerable to climate change will actually go up. Secondly, the possibility of you being impacted by climate change increases as you age, due to various reasons. Now, the world is aging. So both because increased urbanization and because of the increased aging, even with the little evidence that we have now, the impact of climate change on health is going to be felt more and more. Therefore, it's urgent that we invest in research, generate evidence on climate change impact, health, and incorporate these solutions into public health and clinical practice, and for the health sector to work with other sectors to move upstream and reduce the factors that are making the situation worse. I'll stop here. Thank you very much thank you for listening.
Thank you so much. I didn't want to cut you off, but because it was interesting what you are presenting. At the same time, I wanted to listen more, but the time was against us. But talking about the changes that are happening, because recently in South Africa, we just had a terrible storm that really the people's house. And when you say that it mainly happened to the poor, it's exactly like that, because most of the houses were down, and now the government must intervene to protect those, to save those lives. But thank you so much again. Now we are going to go to Dr. Sean Patrick. Dr. Patrick has been introduced previously, but because he's presenting for the second time, I'm not going to stop presenting him again. He is a senior lecturer at the School of Health Science, Health System and Public Health at the University of Pretoria. He completed his PhD in environmental health from the University of Pretoria, and he teaches both the undergraduate and the postgraduate. And he's also supervising the PhDs and masters. His research interests include environmental, climate change, and One Health. Over to you, Dr. Patrick.
Thank you very, very much for the kind introduction. Just to confirm, you all can see my slides?
Yes, we can see it very clear.
Great. I think let's start from here. All right. Thank you. Thank you much, everyone, also for the opportunity to be able to present to you now. So if we're looking at the last talk, when I talked about climate and health, now really in the second talk, taking a step further and looking at One Health best practices and looking what are some of these lessons learned. So I'll talk a bit about public health and environmental health role in One Health. The previous speaker talked about the stakeholders. I'll touch on the stakeholders and the role players involved. In almost everything we do, we talk about sustainable development goals. So I'll touch a bit about my reflection on the work we're currently doing as far as the SDGs are concerned, how they are impacting on One Health. Curriculum development, which is important in training the next generation public health professionals and the One Health workforce. And then I'll end with a few challenges and opportunities. These are primarily focused on environmental health and public health, which is my background, and how they need to play a role more in One Health. And I'll end with a few future conclusions and a few conclusions and future perspectives. So my previous presentation, I touched on this slide about the definition of One Health and the role that both public health and environmental health has played. And I think throughout the talks, through the webinar, we have really touched on majority of these, which is quite important in how we look at One Health, looking at the public health side, the research part, environmental health research, as well as training. This slide was shown earlier this morning, and this is in thinking of definition of One Health, where it's really about the sectors and disciplines that are involved, the capacity development, collaboration, communication, coordination. So if we think of the strengths and opportunities, they really fall in all of these, and it's an opportunity to work together and to learn from some of the examples. So when I was preparing for this, I thought about, we know about the three spheres of One Health, but we do know that within One Health, environmental health, for example, and animal health, there's a field of ecotoxicology where a lot of work is being done. But if you think of the SDGs, there is no one SDG that really speaks to One Health. But while I was thinking about this, I sort of mapped out what the SDGs are that are linked to all of these various topics we do within One Health. And you can see by addressing multiple SDGs, we're actually working towards achieving some of the objectives we have around One Health. So when we're thinking of lessons learned, we do know that majority of the countries, Africa included and India as well, we have these SDGs voluntary reports. And often in the voluntary reports, we report on issues around deforestation or on health economics, for example. But our focus on One Health is generally tied to antimicrobial resistance in the plans that we have. And around climate change, we touch on things like regulation of temperature, so on. But we need to start thinking of it comprehensively. And there's actually a paper that was published, I think, 2 years ago, that actually talks about we need a separate SDG solely focused on One Health, because there are some of these issues we need to think about that are so transdisciplinary that it actually means it's the collaboration of a number of these SDGs. So if we think of who are these stakeholders and these role players, and I'm speaking from an African perspective, whether it's as far as the government is concerned, we do know that there's policy legislation, but there has to be this feedback and ground reality between the government as well as local communities. But as One Health stakeholders, the international organizations such as JBI, who are involved in what we're having right now around research and education, where we are sharing our expertise, we're sharing our experiences in order to either have research education that will lead back to NGOs and civil society. These will then again facilitate community engagement, and then we can involve the private sector, etc. So this is really more of the map that I show here when I was sort of thinking about how do we work together. And for me, in achieving some of these One Health objectives and goals we have, it's really trying to get everyone on board, but everyone must have clear roles and responsibilities where they are involved in, as far as One Health training, education, as well as policies are concerned. So I spoke briefly about the COISA project and the work that is being done. And I think it's quite important. And obviously, this is where we start. It doesn't mean it won't expand to the various to different countries. But South Africa is primarily involved as a technical partner because we have certain technical expertise in addressing some of these issues. So I thought I'd just share one example of university in Zimbabwe, where we can, and this is generally the approach that COISA has been using. And there are sort of The one part is looking what are the activities that are currently being done. So one suggestion is that when countries are looking as far as One Health implementation is concerned, what are the current activities that are there? And if you think of it in a project management point of view, what are these work packages? We need to look at what has already been done, stakeholder mapping, identification of One Health education, both in primary, secondary, and tertiary levels, what are the priority interventions. And what each one of the countries has done so far is they have looked at what are some of these activities that can be done. And primarily, majority of the implementation strategies look more or less the same, but it is around really getting the stakeholders involved, deciding on what is a national strategic plan for One Health. How do you benchmark that? How do you roll out training in primary, secondary, tertiary institutions? And then how do you share all of this information? And again, each country has identified what are some of these important issues that they have. So when we reflect on this, we sort of think if you're going to operationalize One Health as such, it really needs to, it allows us to take stock of what we currently have. But the biggest limitation is really in as far as training is concerned. And very often we cannot expect professionals or leaders to be proficient in some of these issues if they are not being trained on some of these issues. So a lot of these are around curriculum development. And about 3 years ago, a pilot project was started. And this is just one slide of the module. But the module involves medical students. These are in their third year medical students, and veterinary science students. These are vets in their fifth year. And the pilot curriculum really looked at putting these students within 1 week in the same room. We talk about these issues around One Health, what from a medical student perspective, what they have perceived, and from a veterinary student's perspective, what they have perceived. And here's a bit of an explanation around to integrate the learning, that it's collaborative learning, interdisciplinary problem solving. And this has given us an opportunity to review the curriculum. And the new medical curriculum at University of Pretoria will start soon. And the intention is then to actually present this particular module in 2 phases. One for the third year, both medical and veterinary science students, and again in their fifth year. But it's really intended to really start at the basics and train your professionals in this concept of One Health, how we can each play a role, and what is this the benefit of doing transdisciplinary work as well as interprofessional education. So very, very briefly, this particular module, so for just to give you an idea, for this year, we had 290 third-year medical students, 170 fifth-year medical students, but taking them through the concepts around One Health, defining the learning outcomes, looking at interdisciplinary cooperation. We looked at things like world cafes, there's virtual escape room, digital artifacts, and really trying to get students to deepen their understanding, but also to look at problem solving in an attempt to capacitate the next generation. So when we think of all of these, it's quite important to really understand in terms of what are the challenges and opportunities, and if you want to institutionalize One Health. I think about 4 slides where I mentioned some of these around policy development and legislation. There's a lot around environmental legislation that needs to change, that needs to incorporate more of these issues around environmental measures into public and animal health. We need to relook at policies around sustainable practices. As far as our own institutions are concerned, if we are going to be looking at One Health, we need to look at what are the dedicated units we currently have. How do we expand environmental health practitioners we have, for example, looking at this cross-sector environmental health committees, where we actually need to have environmental scientists, public health professionals, veterinarians on board to try and address these. But this goes hand in hand with capacity development. And from a research or institution side, we are trying to at least look at the education part. But recently, there's been a lot of funding calls around climate and health. And one of the speakers presented earlier on about the number of grants that they've received. And that is great to actually start doing some of the research within in these transdisciplinary areas we're working in. But none of this research is impactful unless we have community engagement and public awareness at the same time. It doesn't help, having all of these strategies doing the research, but we're not involving communities in the planning phase, in the data collection phase, as well as the implementation or the knowledge dissemination phase. So it's important where there's campaigns or with some community-led environmental monitoring, that there is this partnership between the researchers, the policymakers, as well as the the communities on the ground. International cooperation is important, and such as what we are here for this webinar, to really get a global perspective. And that's what we've been doing, to share what are these best practices. And it's important to do that, to learn some of the lessons. Our environments may be similar in certain respects, but also different in other respects. But how do we really try and learn from that and have this alignment of some of the agreements that we currently have? And this will lead to monitoring, evaluation, and learning. It's good to have all of these put into place, but we need to develop the indicators. And that's sort of where this conversation about the SDGs have come about, where there are some indicators that we currently have. How do we use that and actually see what advance we've made in some of these issues around One Health, but looking at, biodiversity matrices, pollution levels, and so on. And that really strengthens the argument for one SDG with targets and indicators as well, looking specifically at One Health. And it's important to regularly conduct these environmental impact assessments to actually see if we have been doing some of the work. So I think this is my second last slide. If you're thinking of what are some of the next steps, so as University of Pretoria, we do have a One Health platform where there's work being done at it's in Mpumalanga province, where the veterinary science faculty, as well as health sciences, where there's a community engagement work, there's a human health clinic and an animal health clinic as well, where we are involved in trying to address some of these issues, both practically, so on the ground, and some of the theoretical concepts around there. And as a country, majority of the universities are involved in an Institute for Pandemic Prevention and Preparedness. And around all of these, you'll see there are there's 6 thematic centers that are there. But within all of these, especially around number 1, around preventing pandemics, with a focus on early warning systems, for example, there's quite a big focus on One Health, where we're really trying to understand and to unpack some of the issues that are there, but trying to integrate all of these and trying to also look at capacity development. So I do think there's quite a long way to go. I do think that what we have learned in some of the work we've been doing is that through all of these organizations, through COISA, through the institutions we're involved in, there's a lot of work that has been done around One Health. The next steps really needs to be is how to incorporate that into some of the local frameworks we are doing. And just to end, to say that I have a PhD student that will start next year, and his intention is in South Africa looking at One Health and seeing how that can be incorporated into some of the national strategic plans we have, so that we can develop these indicators, and we can monitor and see, are we making progress in terms of education or in terms of policy development within the local government itself. Thank you very much.
Yes. Dr. Dr. Patrick,
yes.
Your presentation is very good. Basically, I am an One Health expert. I've been working in India for a very long time in respect of One Health. I'm basically a veterinary public health expert. Even yesterday, I have attended one roundtable organized by GIZ and Ministry of Environment, Forest and Climate Change in our country. and this is the highest level policy making authority in our country. You see, actually, what I wanted to share with you that we must give our proper emphasis on intersectoral coordination, because in every country I have seen that in every country the intersectoral coordination is a very big problem, and we have a lot of egos between medical, veterinary and environmental experts, and we are unable to share one platform and unable to share the data, which is very, very important. Data management is very, very important. Another one thing I would like to inform you that
Chair, do
due
we
to
have
this
another presentation?
climate change.
Can I disturb you? May I like as we have scheduled the meeting, can I put you on the during the discussion time, the questions and answers, then we can continue from there. Just to follow the
My apology.
No problem. Thank you so much, Dr. Patrick. I understand Dr. Sadanama that he can't control himself because this presentation was actually very good. I'm also very impressed. But now I want to introduce Professor Ghosh. Professor Ghosh is, I hope I'm saying the name right. Professor Ghosh focuses on impacts of climate change on community health and healthcare delivery systems. Her research aims to understand social vulnerables of the communities experiencing climate change and also throws light on the planetary health dynamics, impacting transformational changes towards climate-resilient health system. She is actively involved with teaching environmental health and social and behavioral science in the public health management diploma. And she also, together with the Masters of Public Health. Prof is actively involved in national and state level plan and policy formulation under the National Adaptation Plan for Climate Change and Human Health. Over to you, Prof. Ghosh. Please share your screen if you can.
Yes, thank you so much. First of all, thanks. I would like to thank the organizer to giving me this opportunity to speak in this event. And my apologies also that I cannot share my, I cannot show my video. The connection is not very stable. So, it is. Can you see my screen?
Yes, I can see your screen, but may you please mute your slide, those that are talking on the side, may you please mute? Yes, I can see your screen. May you please put it on the share mode, please?
Yes,
That's
yes.
it.
Is it
So
fine
much.
now? Okay,
Thank you.
Thank you so much. So the thing is that since morning we are discussing the climate change, One Health issues, and the challenges the world is facing. We all are facing in today's world. So definitely the One Health is a very complex and complex problem which coincides the human health, animal health, and the ecological health. So this complex system needs interdisciplinary solutions. So if we see that, this complex pathways of how any zoonotic diseases are impacting us human. So we can see the example of avian influenza. So like here, if we see this diagram, it's so complex. It depends on many factors. Even Dr. Son already shown that how the SDGs are connecting with all those One Health problem. So it has the human population growth, it has socioeconomic development, the infestations of agronomy, land use changes, climate change, changing in the habitations of the bird migration patterns, the risk of spilling over with the humans, vulnerability of the geographical or genotypically vulnerability. So, and ultimately it is impacting the food system and the food sustainability. So this is a very complex pathway of just one zoonotic disease or one of the major One Health related disease. So if we really wish to solve this kind of complex diseases and the changing disease transmissions in today's world due to the environmental changes, what we need to understand that we definitely need a transformative approach. So with our stereotypical, hello, is it clear? Am I audible?
Yes, 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 you are audible. Please go ahead.
Yeah, okay. Yeah, so the transformative system means that we need to bring back our traditional knowledges. We need to focus more on the indigenous knowledges, that how the nature and human interactions was actually started and what is the history of this, One Health perspectives. Then definitely we need the system approach. That means understanding a problem with a holistic understanding. So we need to understand what are the system in which this animal health, human health, and the ecological health are connecting together, how they're interacting, and how this structure and functions are actually happening. So this system approach, this holistic approach, we definitely need. The next component we need, which Dr. Sean has also mentioned, that interdisciplinary understanding, interdisciplinary responses. We understand the problem of One Health through different lenses. Like one is the veterinary lens, one is the communicating disease lens, other one is the environmental lens. But we need to bridge these knowledge frames together to understand it is a holistic problem. Then definitely we need to understand the socio-political and cultural system, how this people's food system happened, what are the human nature interactions in different communities. For example, in Nipah virus case, so people in that particular region of Kerala, the Indian state, they're very they have a practice to eat the fruits which are available on the ground. So that's how the Nipah is like one of the reason, not the whole reason, but one of the major reason is their food habit or food system to collect those fruits and eating it without any washing or any processing. So this kind of cultural system, cultural practices, social practices, we need to understand if we really wish to solve this complex problem. And these are basically the underlying principles which is necessary to implement a One Health approach. Then our health system is already burdened. How can we incorporate, if we see that how we can incorporate those complexities into our primary healthcare system specifically, because primary healthcare system is the first point of response for the people. So it is, our primary healthcare system in India is facing the challenges of affordability, acceptability, availability, and also the parallel healthcare markets. So all these challenges our healthcare facilities are having, which is getting widened by the present day environmental hazards like the climate change. So Dr. Rajiv has already mentioned in details, like there are infrastructural damages due to flood and cyclone, which again prone to make the people more susceptible towards the communicable diseases. Then the loss and damages in the supplies, making the health care system inaccessible, hard to reach areas, mostly the tribal areas where people need it more. There is no such, the veterinary primary healthcare is also getting shut. So, and another major problem is the untrained human resources. India has taken so many efforts on the One Health aspects, but how much those trainings are percolated to the frontline health workers to deal with such complex problems. So the excess heat is also changing the disease dynamics and making the job more tough for the frontline health workers. So we are putting the blanket approach in everywhere, which may need a paradigm shift to more contextual program and more contextual understanding. So with these challenges, as I mentioned, that India has already taken so many programs and mission of One Health. So there are IDSP, Integrated Disease Surveillance System. There are surveillance program for communicable diseases, the Pollution Control Board, the Climate Change and Human Health Program, drinking water, food and agriculture organizations. There are supporting organizations from the UN bodies like WHO and other international bodies. So, and national and international bodies. So all of them together are actually trying to solve the One Health problem. But still now, why we are still struggling to fix the problem or handling it with a more effective manner might lays in the problem of three kind of uncertainties. Like the first definitely is the knowledge uncertainty. How much the policymakers and planners are actually experiencing this climate and environmental health link with the human and animal health. So there is a kind of knowledge uncertainty in terms of the policymakers. There is a science policy disconnect for sure, because we all may agree that the policies are in a country like India and most of the countries in South Asia and Africa also are mostly politically driven other than the evidence driven. So, and of course, there is the evidence uncertainty itself, because there is limited data, limited empirical and primary data, or the people's experiences, why these problems is happening. So all of these uncertainties are actually making the One Health approach like less prioritized, or it is still not gaining its required priority in the primary healthcare context. So now there would be two questions. So, like, to what extent the healthcare delivery system is prepared to take up the One Health challenge, that is the combining the environmental, animal and human health, and how much it can effectively engage the vulnerable communities, which can be embedded, their behavior, their participation can be embedded within the health system, because India still have the health system community representation in health system, but which is mostly in pen and paper in many places, without any formal, without any active engagement. So definitely, if we wish to answer these questions, we have to understand the One Health history. That means the human nature interactions and how it is culturally and socially driven, and in which we definitely need the community knowledge to be in practice. We need to critically engage with the interdisciplinary teams, intersectoral system thinking to achieve an integrated health outcomes out of the One Health approach. We need to recognize the importance playing a One Health approach to identify and tackle the current health system challenges. That what are the challenges we need the One Health approach, through One Health approach, we need to solve. So those complexities we need to understand, and those knowledge needs to be applied through a system, through a structured systems which can support the public health system to implement the One Health approach. The urgent need of the hour, that's the most prioritized things should be that, analyzing the primary healthcare's vulnerability towards the One Health aspects, and how the veterinary primary health and the human primary health workers can work together. How can the surveillance system in a very localized area can be modified can be reached, can be communicated. The risk communication in this section is very important. And for that, we need to conduct training of the primary health workforce to bridge this knowledge gap. We need to incorporate, implement any participatory model of engaging the community who are handling the animals, who are rearing up the animals, and how this human and animal interactions, their knowledge need to be built, their capacity needs to be built to handle these interactions and inform the risk quickly to the health system. And definitely for both the aspects, we need a constant facilitations with policymakers and advocating the community participations. As researchers, as civil society, this is the most important role we can play. We also need to highlight the contextual risk and pathways of impact through different socioeconomic factors. As I mentioned, that community participation is the key in this process. We need to influence the evidence-based resource allocations for the primary healthcare to implement the One Health lens. And definitely the local to global knowledge assimilation, which we are actually doing today, sharing the experiences between two countries, that is, more and more needed in these sectors. So that's all from my side. Thank you so much.
Thank you so much, Prof. Ghosh. I think everyone has got a very important impact in this presentation, and we are all wishing to talk and share our views. But I'm going to introduce my co-chairperson, who is going to share the discussion with everyone. Dr. Chanchal Bhattacharya will be the one who's doing the questions and answers. Doctor has expertise in risk assessment, risk analysis, livestock-based antimicrobial resistance, rabies control, animal health control, animal birth control, and disaster management in animal husbandry. Currently, he holds the position of country lead in the USAID Transform project and at Haifa International. Prior to this, he was associated with the government of Delhi as District Animal Husbandry Officer, New Delhi, and a member of Secretariat DSPCA. Over to you, Doctor, and then it's your chance to ask the questions and answers.
Yes, actually, I have very minutely listened to all the speakers. Initially, I would like to come to Dr. Rajiv Sadanandan. Dr. Rajiv, you have highlighted about the issues regarding climate change and health system. Accidentally, yesterday I have attended one health roundtable conducted by Ministry of Health, Ministry of Environment, Forest and Climate Change, along with GIZ. Very interesting findings were there in this project. Actually, I have raised one question which I would like to share with you. This is disease ecology. As far as we know that the typical disease ecology is changing. Right now, what we have seen before 10 to 15 years back, right now we are not seeing this. That trend of disease is changing and the disease dynamics is changing. So in my opinion, that when we are talking about the climate change, we must consider these points also, because you see, actually, if we cannot track out the disease, then it could be very difficult. As an example, yesterday, I'm just giving you an example. Yesterday, we were discussing about Kazanur forest disease. Okay. Initially, the Kazanur forest disease was confined in a particular state, but right now we have seen it in Goa, in Tamil Nadu. I would like Rajiv to highlight about it, if he can give us some precious points.
Kaisanur, for us, this is just one of the diseases that have happened due to animal, human interaction, and also partly because of the pressure on the It actually happened at Wayanad Forest Reserve, where the disease was first noticed. In fact, I was health secretary at that time when we didn't know what this disease was. One of the problems in India is that our surveillance is not good enough to understand what exactly is the prevalence of disease. For example, Kaisanur forest disease is now prevalent. I think at the latest figure is at least some 8 to 10 states in India. Now, that may not be the only crossover infection that we're having. We may have many more. Unfortunately, the level of surveillance, and unlike in the OECD countries, India does not have an observatory of diseases where we look at what is the way the disease patterns are changing. So we get caught out when we should actually be preparing for it. And that is I think the lack of proper surveillance is what is causing what is coming as a surprise for us. For example, Nipah is the best example. Nipah broke out in West Bengal as a crossover from Bangladesh, but then it emerged in Kerala. Now, do you think the virus actually took a flight and came to Kerala? It would have crossed through many other states, and then so we're not even tracking it. So one of the big problems of looking at the disease profile in Kerala, I mean in India, is the lack of good surveillance, and secondly, the lack of communication between the animal health and the human health. Except for a few diseases, there's very little sharing of information. It's not happening in antimicrobial resistance because the antibiotics are being used in both human health and animal health, and there's a lot of pathogen crossover that is happening. We're not tracking it. Because of habitat destruction, crossover, like what happened the Kaisanur forest diseases are being transferred from wildlife into human. We're not tracking that. So when you say trend, unfortunately, we are not able to watch that trend and we get caught out when it erupts. That's a sad part of India's public health. I'll stop. Thank you.
Thank you very much. Thank you very much. I'm thoroughly agreeing with you. One thing here I would like to give an input that yesterday we are also discussing about the wildlife health. In India, wildlife health is absolutely compromised, and basically, if we are analyzing the environmental situation in our country, then you will see that there is a degradation of our forest land, and the buffer zone is vanishing gradually, and the interaction between livestock, wildlife, and human are increasing day by day. So this is another one major factor of jumping pathogens from one species to another. So I think that if I am coming to the next speaker, Dr. Patrick, he has explained the intersectoral coordination and capacity building, veterinary and medical education like this. You see, actually, I remember that in Public Health Foundation of India, when I was a member of Roadmap of Juno team, at the time one survey was made among the medical students, MBBS students. At the time in 2012, only 3 to 4% medical students knew about the concept of zoonotic. And in medical and veterinary curriculum, there are a lot of zoonotic diseases which are included, and an understanding was grown among the students, and I'm hopeful that in future also it will be increasing. And simultaneously, there are some other institutions who are undertaking some One Health course, maybe certificate course or diploma course like this. In a year, last year, I also taught in Kharagpur IIT when they have launched their certificate course in One Health. So this is important. I'm just sharing with you. I believe that some community-based approach should be developed in our country, which we can learn from Africa. in Africa, when the Rinderpest eradication program was going on, at that time, participatory approach and community-based approach has been developed for Rinderpest eradication program. So there is a concept. The concept is available from FAO, Food and Agricultural Organization, United Nations. We can borrow it for community-based approach. Actually, Professor Ghosh has told us regarding this community-based approach. Basically, if we are analyzing the current situation in India, we will not be finding out that there is a proper community-based approach. Something ASHA workers, they are working in respect of human health, but in case of animal health, this is very confined. The approach is found in few states. Some Pashu Shakhi from Krishi Shakhi. This concept has been developed by Ministry of Rural Development. But I think that we should come over and we must make some common concept about the One Health community workers. I would like to contribute a few things. Dr. Ghosh has given a very good presentation about the avian influenza. Basically, the situation is very rapidly changing in the world. The movement is very fast right now. The business related with animal food, the production is taken place in one country and the end product is sold in other countries. The value chain is developed very rapidly. So there are a lot of very complex things. Even if you are considering the rampant urbanization in our country, then you will find that the illegal dairies are there, and from illegal dairies also there are a lot of pollutants generated in our environment. Then we worked about the threat perception of brucellosis in as a part of urban zoonosis in Delhi. I personally worked there with Public Health Foundation of India. There is a project. So there are a lot of factors, you see, and mostly if you see, then the sufferers are basically poor people and illiterate people. I would like to invite Dr. Patrick and then Dr. Ghosh for giving their input, valuable inputs. Dr. Patrick, can you please?
Yep. Thank you very much for that. Yeah, I do think it's quite important as far as education is concerned. I mean, and you had mentioned, like in 2012, yes, the discussion was there, but I think the benefit of the pandemic really highlighted zoonotic diseases, and also it showcased that the basic understanding is not really there, even from as far as the medical students are concerned. And I do think because we now have the opportunity to teach some of these courses virtually, there is an opportunity to get the experts around the world to be involved in some of these course developments, the discussions, these in order to have the general public also understand some of the terminology we're talking about. So I think in terms of education, we have made great strides, and this is in all countries across the world. I do think in countries like South Africa and India, for example, some of these issues are practical and are more relevant compared to some of the other countries, not diminishing any problems, but we have real issues on the ground that actually need us to develop these solutions themselves, but we need to train the next generation. So as far as the medical curriculum is concerned, you are correct. I think we in South Africa, Pretoria, we've taken a step towards trying this out. So for the last 3 years, we've actually piloted, and the feedback, and understandably so, in the third year medical students don't necessarily have the in-depth knowledge on zoonotic diseases like the veterinary students have. So this was just a pilot phase, but moving forward, we have both students in their third year seeing sort of the basic concepts, and in the third year, when they've gained more knowledge, more application, the conversation would sort of move better from there. But if you think in terms of masters of public health, the public health education, yes, you've got a lot of things on disease control, environmental health, but not really. All universities don't really have a degree in One Health. Now, recently, in the past 3 or 4 years, you've got Master of Science in Global Health, Master in Science, Environmental Health, and One Health. Those have only come recently. We've been teaching this for many years, there have been zoonotic diseases. It's been taught in many different forms, but we're calling it One Health. One Health is not new. I think people must not forget it's not a new concept that was born last year. It's just been mentioned different things. We've always taught human and animal interactions as sort of one component. We've taught animal environment interactions as one component. So I think now is an opportunity to look at our curriculums and just repackage what we have. I think the people should not be afraid of that. The conversation really, and that's why I said when I talked about, looking at what we currently have, we can make great strides in greater education and greater policy implementation, not by reinventing the wheel, by simply taking a step back and seeing what strides have we made. Like you may mention now, as far as community engagement is concerned, we have all of these teams on the ground. It's nothing new. It's just rethinking. And I think that's the fear we all have. We have this fear of saying, how do we just change the narrative slightly from that it's now no longer just community health, it's now One Health with a community perspective and focus. I think that will be where the next big challenge is, this paradigm shift in thinking about One Health as a concept and just moving away from the other things. Thank you.
Actually, you see, the One Health concept has been developed by Dr. Schwabe, as far as I remember. Okay, one medicine, one health is usually using this, and the One Health terminology was absent there. We have been working with zoonotic disease for last 25 years. Myself, I'm working with rabies for a very long time, but the One Health terminology was absent. It does not mean the One Health concept was there, absent. But you see, what I feel, I have been working here in government and in international organizations. What I feel that under one umbrella, all the stakeholders should be brought, and all the stakeholders should be given their specific responsibilities to implement. Because you see, I was a nodal officer of avian influenza in Delhi. Delhi is the national capital, and all the embassies are here, all the international organizations, UN organizations is here. So we have faced a very, very tough problem here. When the question of intersectoral coordination is there, everybody is telling that, okay, we'll do by paper. But the implementing, as because we are the implementing agency, as an example, I was representing Animal Husbandry Department. So we are the sole candle bearer. You see, nobody is there. You are doing everything. So this is not correct. The approach is not correct. And we have to think over, and we have to create a centralized command for that. And another one thing I will tell you, that the approach should be risk-based, practical approach. If you are applying theoretical concept, then One Health will not succeed, in my opinion. Maybe somebody may differ with me, but this is my opinion because I have been working in this field for a very, very long time. So I have seen that if we are preparing as risk-based approach, and risk management, risk communication, etc., will be in a proper manner, then only One Health approach should be materialized in future in a very proper manner. Thank you. I'm inviting Dr. Ghosh if she can contribute something.
Yeah, thank you, sir. Yeah, I agree with you and Dr. Patrick that we need to target the different set of stakeholders with different risk communication strategies, so that we can all understand and come to a platform to act upon or take actions in the human and animal interaction phase. So definitely, see, yes, we have the zoonotic disease, we have the communicable disease for long, but what is the public health importance, or how we can understand that this problem can be solved in the present changing disease dynamics in India towards the environmental causes. So that is very important, and this kind of perspective should be there in our medical educations and public health education, definitely. So that's how we can create a next generation cadre, medical who can understand the cause and the causal loop, this animal human interactions, and try to solve the problem. So this is definitely a very important step that India should take. This is not a new issue, but maybe we need to change the perspective towards the One Health approach. So that is one major thing. And definitely I again try to focus on the community engagement in terms of, increase the health system's resilience towards this changing disease dynamics of human health interaction. So this is a very important part, and definitely the NGOs, civil societies, and the vulnerable communities, their risk communications should be more strengthened so that the health system can be, response towards their need in a more effective way. Thank you.
Thank you, Dr. Ghosh. Thank you very much. If anyone wanted to contribute, then we can listen them also. If we have time, definitely, provided that we have time.
We have a hand from JP.
Yes,
Dr. Basu's hand is up.
Dr. Basu.
Yeah.
Dr. Basu's hand is
Good
there.
morning.
Kindly.
Good morning. This is Dr. Basu. I like to thank to all the speakers for very informative sessions. And I have a common question to all the speakers. If anyone or all of you can project something on that, that is the effect on maternal health of the climate change. So apparently there are certain types of maternal and child health effect which can be caused by the climate change. So I just wanted any speaker or all of you just throw some lights on that. Thank you.
Dr. Sadanandan, you may highlight something.
Yeah, I mean, actually, you landed me in a major spot, because the current, apart from the general, impact of dehydration and others that happen, I'm not aware of anything that is specific to maternal health. Most of the impact that we know actually look at cardiovascular, diseases, cerebrovascular. There are mental health issues. There are issues with infectious diseases, especially vector-borne, waterborne, and foodborne diseases. But I mean, my studies I've not been able to pinpoint anything that is specific to maternal health, except the overall dehydration and and all these factors that I mentioned, which is the impact of weather that operates to other areas. Something that is focused on mental health, I'm sorry, I'm not able to come up with. May anyone else in the audience, if you'd like to, that's a very interesting question, and I'll certainly look for answers in future. Upasana has an answer to it. Yeah.
Yeah, thanks. The LHSTM, the London School of Hygiene and Tropical Medicine, have done some studies in Burkina Faso, and they found that the heat impact on the maternal and child health is basically many women are having preeclampsia and low birth weight babies, though yet to be established more concretely. But there is a link they found between the low birth weight baby and the increased heat, indoor heat. So that is a channel they want to establish. We at Public Health Foundation of India, and along with the Institute of Meteorological Department in Pune, we are also trying to do similar kind of research in Indian context. But we are yet to come up with our findings. But definitely it is in a process of establishing that there are direct heat impact on the maternal and child health, especially the pregnant and the neonatal health. So, and this is the direct impact, but definitely the climate change has more impact in in more indirect pathways in terms of floods and cyclones, impacting the agricultural productions and food insecurities, and also the mental health. So like it is increasing the anxiety and phobia and aggression during the heat summer hot days. So there are indirect and direct pathways of climate change impact on the maternal and child health, which need more evidence. but definitely the evidences are coming across the world. Yeah, that's it from my side. I wanted to add. Thank you.
Thank you. Thank you very much. I don't know whether Dr. Basu has got her answer or not, but thank you, Upasana, for your contribution. I believe that this is a very unending process, and if we are talking, we keep talking about it. So I believe that let us share our email in future also if we need to get in touch with each and everyone, because we are working on One Health, we are working on climate change. So we can share our email and we can be in touch in future. This is my suggestion. I have already shared my email. Patrick also shared. So please come forward. And if anyone has any question, he or she can raise his or her hand, and they can ask the speakers. If there is no question, then we can hand it over to our organizers, because I think that already is time. From
I think you're the one who's supposed to do the closing. I think we're done from here.
Okay, then I must be very, very grateful that I have been invited here, and I come across with all sort of different views about One Health, climate change. I'm really grateful, and I'm looking after for future time if anything will come out. As an example, if we are sharing our views among us, then that will be wonderful, because everybody is having their own view about One Health and their own expertise. So if we are sharing this expertise for our future development, I believe that it will be very, very beneficial, not only for us, but also for other participants. And from that, I wanted to conclude today's webinar. I'm really very thankful to the organizers who invited us here and gave a platform to share our views in contemporary topic. This is a hot topic. One Health is a very hot topic. So I'm really grateful to each and everyone. So thank you very much. We'll meet you, each other. Keep in touch. Thank you. See you again.
Thank you. Thank you so much.
I just want to introduce Dr. Paramita Bhattacharya, which she's supposed to be doing the closing. She has MPhil in economics and PhD in economics. She is a research focused on health financing, health economics, and economic evidence. And she's also at CPHR. She leads the grant proposal writing, co-leading of research projects, and supervision of junior team members. She was awarded Dr. R.T. Doshi First Prize for her paper on India's National Food Security Act 2013, food distribution through a revamped public distribution system of food stamps and cash transfers, and the Best Paper Award of the International Conference on Managing Critical Resources, Food, Energy and Water by CEDP. Over to you, Dr. Bhattacharya.
Thank you so much, ma'am. Am I audible?
Yes, you are audible.
Thank you so much. We had very nice presentations. Thank you all. And on behalf of the organizing committee, it gives me immense pleasure to propose the vote of thanks. I would like to start by thanking Dr. Madela and Professor Joe Jordan, who honored this function with their inspirational and insightful thoughts. Next, I would like to extend my heartfelt thanks to our distinguished chairpersons, Professor Hugo, Dr. Mukherjee, Dr. Bhattacharya, and Dr. Magida. Thank you so much. And with the deep sense of appreciation, I would like to extend my heartfelt thanks to our distinguished speakers, Dr. Parameshwaram, Dr. Patrick, Dr. Sadanandan, and Dr. Ghosh. I would also like to take this opportunity to thank all our enthusiastic participants for taking time out and participating in our event and making it a great success. Last but not the least, I humbly thank Dr. Jayati, Professor Debashish Basu, and Dr. Mukherjee, and the teams from University of Pretoria, JBI Ekurhuleni Clinical Research Center, and JBI Center for Evidence Synthesis and Implementation in Indigenous Health. Their all efforts have made this program a great success, and we look forward to more such events in the future, and we are excited to plan such events in the future, and we appreciate your support in this regard. Thank you so much.
Thank you, everyone. And this was a very fruitful presentation from everyone from India, from South Africa. I am so grateful to everyone. I'm hoping we're meeting tomorrow again. Thank you, everyone, and goodbye.
Thank you, everyone. Bye.
Thank you, everybody, and for the attendees as well. Thank you so much.
Goodbye.
Goodbye.